Welcome to our webinar. We have a lot to cover, so I'm going to get right to it. We are Pierro, Connor, and Strauss, and EverHome Care Advisors today, and my co-presenters will be Peter Strauss, our partner emeritus in New York City, and Nora Berrado and Susan Vail, who are care managers with EverHome Care Advisors. You'll see our agenda there: caregiving trends and challenges, the journey of the caregiver, the document checklist, things that should be there and need to be there, putting a team together to deal with the issues that caregivers face, the upcoming changes to the Medicaid program, which are going to change the landscape for many people, and then advancements in technology and new and exciting ideas that are coming to the market, some of it fueled by the COVID crisis. Have you cared for an aging parent or a loved one? Do you know how to find care? Can you protect that parent and keep yourself and your loved one safe? And I think this is something that applies to all of us. The systems that we have are stressing tremendously. Is there going to be care there when we need it? I am 62. Hope I don't need it for a very long time, if ever. But what's it going to look like 10, 20, 30 years from now? What is the care market going to look like? And how can we prepare ourselves and our clients? This is 20 years ago, my mom. And I got into the caregiving world as a caregiver through her experience with Alzheimer's. And she was diagnosed at the age of 80, passed at the age of 88. So for 8 years, we dealt with the progression of Alzheimer's, dementia, and all the issues that a caregiver faces. And my mom in our family was the rock. She's the one that everybody went to when they had a problem. So I tried to put together 20 years ago a plan for my mother, and I was an elder law attorney, somewhat experienced even at that stage. But the phone calls that I made to all of the various agencies, the groups that I thought could provide solutions to me, I did an eternal loop. The last number I called was the first number I called because I went through every different referral without getting a hands-on solution. And I was then very fortunate to find a care manager by the name of Joe Jackson. Not the baseball player, but Joe Jackson, the care manager. And Joe was based at the time and still is in Lenox, Massachusetts. He is still an active care manager in Lenox. Joe came in. We did the normal thing when you have someone with dementia who is very reticent to have people in their home. I brought Joe in as my friend. Joe, Mom, this is Joe. Joe, this is my mom. Mom, I have to go upstairs for a minute. Do you mind if Joe sits down for a few minutes and waits for me till I come back? No, that's fine. Joe calls me an hour later. He had done a full and thorough assessment of my mother, and we got direction finally and help finally to find the care that my mother needed. And Joe led us through that experience. Caregiving trends in the past 5 years, having done it, I know that it affects caregivers' own health, especially when the caregiver is a spouse living in the same home and they're providing 24/7 care. Caregiver burnout is something that we are seeing more and more of, especially with all of the stressors being put on now due to the COVID crisis. These are some statistics. You can see that in the last 5 years, just in 5 years, the numbers just keep trending up. And what's going to really swamp the boat is the baby boom generation. I'm a baby boomer, but the front edge of the baby boomers are now in their 70s, turning 70. So in 10 years, they'll be turning 80, and then they'll be in need of care. Now we've got another generation of caregivers coming up and a very large population of people who will be coming into the care system. So the impact of COVID-19 has been significant in all of our lives, and that's no different with regard to the care that's being provided to our loved ones. So I'm going to bring Susan Vail on now to participate in the discussion. And Susan is, again, one of our care managers who has significant experience as a social worker, working with clients and families through the aging continuum. Susan, what have you seen that has changed during the COVID crisis?
Well, a lot has changed. Like our slides say, access to services, it's so much harder to access because many things were shut down or are still shut down. Where you could check on your loved one in a facility or at their home and visit them because of precautions and have abundance of health and safety, you can't go see them. Unfortunately, many of our seniors are not as apt with technology, with iPhones, tablets. So having that FaceTime, the Zoom is overwhelming for them. If your loved one has to go to the hospital, whether it's the emergency room for an outpatient procedure or seizure or surgery, you can't see them. You drop them off at the door and that's about it. And with a pandemic, we don't know where things are going. We know we're moving forward. We will get through this. We have gone through other pandemics before, but it creates a different level of stress, which we already had when we were caring for our loved ones or caring for someone. For many of us, we know that our population is aging. In 2019, there are 3.4 million of New York's population 65 and older. The reality is in less than 10 years, we anticipate that to increase to 4.34 million. How are we going to meet this need? And for those over 85, you can see it's the same trajectory, 483,000, and we're anticipating, and this is an underestimate, 619. And we have to look at how we're going to do that. And one of the issues we face is workforce and the demand. As many of us know, or as caregivers, as you're finding out, there is a caregiver shortage. And there, as you can see the statistics there, there's 23% of the home health aide jobs that are unfilled, 21% of LPN or RNs, and for therapists, 13.5. And what that means is we have to be creative to find that care for our loved ones. And how are we going to do that, either for the clients we serve or for our loved ones? So one of the contributing factors are their health or their physical impairments. And as it's very obvious, those age 65 and older, as we get older, health needs change, some other health needs come to the forefront, and it impacts our seniors and their ability to be independent and to be able to have their needs met.
And Susan, the cost number there is something that is somewhat staggering. And if you follow the state budget, as we do very closely, which originally led to the budget that cut Medicaid home care services, and we'll talk a little bit about that toward the end of the presentation. Mm-hmm. The state budget is under enormous stress right now, as is the federal budget. The federal government can print money and add to the deficit. The state cannot. So the impact on the programs that we have due to the COVID crisis and the shortfall in the budget, when the cost of chronic conditions is going to $864 billion in 2040, that's a staggering number. You can see that there is going to be an ongoing problem with the ability to find care, pay for care, coordinate it, and do it on a cost-effective basis. When I dealt with this with my mom 20 years ago, what did she need? What would have allowed me to be a remote caregiver? She only lived an hour away, but that hour drive on a daily basis got to be very, very burdensome when you have a spouse, when you have 3 young children, when you're a coach of the Little League team and the Pop Warner football team, and you're living a life that needs attention, and now you're in that caregiver role. What do caregivers need to improve care for the patient, to relieve the pressures on those caregivers, and to keep their own health intact? Because it wears you mentally, and when you wear mentally, you begin to wear physically. So Susan, there is a profession that has grown up over the last number of years, and that's part of your profession.
Yes, it's the Aging Life Care Association. It used to be the Association of Geriatric Care Managers, and I'd be remiss if I didn't thank Peter Strauss, one of our senior partners at Pierro, Connor, and Strauss. But Peter was one of the original counsels for the Association of Geriatric Care Managers, which is now called the Aging Life Care Association, and helped formulate the guidelines, the ethics. So thank you, Peter. for your work and your expertise.
Well, thank you, Susan, for mentioning it, but I want to say that the reason I did that work and got involved is because I saw that lawyers were just one piece of the team that was going to help caregivers. And I saw the need to have a partnership and design their guidelines and standards of practice that would be mutually beneficial for our constituency.
Yes. So thank you, Peter. So we take AIM, assess, implement, monitor. We're one stop, so we're able, someone can call us and we can guide them, as you can see through the diagram there, through all aspects of care. We have developed relationships with providers, so we're able to navigate through that quicker and easier and alleviate that caregiver burden. And all they have to do is make that call, which alleviates that stress. And as you'll see in our next slide, EverHome is not a home health agency. We do not staff, but allows me to have the flexibility to match the client's needs with the agency or the caregiver. Clients can pick their own individual. With many of the programs that are available for care, they can even pick their own family members or neighbors or loved ones. The reason we do this is to meet the needs of the client. The home health market is underfunded and fragmented. As we know, there's the caregiver shortage. And many of us know that Medicare doesn't provide the care that we originally thought it would way back when. And one thing families need to consider are the legal requirements and the financial burden, financial requirements when hiring a caregiver.
And we have a diverse audience, Susan, from all over the state
Yes.
and from other states. So the market is different everywhere you go. In New York City, agencies have staff that they can hire that can staff cases. But in very rural areas in upstate New York, even here in the Capital District, when you call an agency to staff your case, very often they just don't have people. They don't have the ability to put a case staff together. And so you have to go to the next level. And your job, Susan, is to look at all of those care options and to find the best care possible to place in the home. But when you're hiring outside of an agency, there are other issues that come up as well.
Yes, payroll, workman's comp, a whole bunch of things where I hate to use the term, there are some families that still pay under the table, but there's so much risk and liability that we can help guide of what's going to be the right solution for that family and for that individual. And we envelop the whole care team. So there may be other care managers, other providers, and we can, as a team, look at what's the best for that individual and family.
Yeah. For those of you that have attended our Elder Law Forum, this year, as we have in past years, we had a panel on home care. Al Cardillo, who's the head of the Home Care Association, was one of our panelists. And he talked about the challenges that the home care industry is facing right now. When people come in to see us as lawyers, Susan, they come in, and I would say as many as 50% who have accessed care have done it on a referral of a neighbor or somebody in their neighborhood or a family member, and they're paying under the table. It just is the reality of the system. And we try to fix that. We arrange for payroll services and all of the proper insurances to make sure that they're covered legally and they don't get themselves into trouble. But it's a big part of the care needs going forward. And you saw those shortages. Al Cardillo talked about that as well. How are you getting people to work in an industry where the rate is $12 an hour, where they can work at McDonald's for 15? It's a very, very difficult dynamic to staff those agencies, and a problem that we're not going to fix in the short run. So having the ability to change out parts, find the care where you can find it, and find ways to pay for it, which we're going to talk about later, is absolutely key. I'd like to bring Nora Berrado on now. And Nora, if you could join us. Nora has a great deal of experience both in the hospital setting, in the care management setting. She was the head of discharge planning and wore a number of hats at one of the major local hospitals. And now Nora works assisting families. And we're going to walk Nora through the stages and the crisis stages. So give us an introduction and take it away.
Well, I'm glad to talk about this issue because it's near and dear to my heart. The caregivers, for most of my career, have really struggled with trying to meet the needs of their family and meet their own individual family, and in addition to their elderly parents. And it's often they're in a crisis stage. I can just give you a little bit of experience. I started kind of my career backwards. I started in a long-term care facility. One of the things that I found back when I started is that, we often use nursing homes to deal with the aging issues in the elderly. And what I found is in the first 4 to 6 weeks, many of the elderly people were able to go in their community and go back into their apartment. But the problem was some of them gave up their homes, and they would come down and say, is this all that is left to be? And it was totally unnecessary. But what happens is you get into a crisis with a caregiver and you follow along in a system that is not compassionate to caregivers. It is very focused on managing the cost and moving people along. And that caregiver is then required to drop what they're doing and take immediate action. And they become the quarterback of trying to get the decision-making documents, available healthcare proxy power of attorney. Where are they? Do they have them in place, and are they correct? And then they also have to make the insurance decisions and move that person in a very, very fast-paced environment. So that's the journey of a caregiver today. And it is really, really critical that they know and understand the different levels of care and what their rights are as they're moving across that system. And often, the care manager in the hospital or in a post-acute facility is really focused on, yes, meeting that person's needs, but they're also focused on making sure that the insurance doesn't cut and that they're moving them to the next level of care. So what we really focus on is our role is different as a care manager or a care coordinator. Those terms are, changing. There's many different roles of care managers and a care coordinator, but we call ourselves care coordinator, and we're focused on that caregiver, that consumer, and following what they want as their plan. And so often what's important is that you need to have those documents in place, and you need to know what the goals are and what that loved one wants. And then when you're in that hospital situation, it's really important that you know who the advocate is. And if you feel you're being pressured going to the next level of care and that you're not getting your answers to the questions answered, that you contact the patient representative or ask for the social worker within that facility. There's many issues that you need to be aware of, but the most important thing is what the patient bill of rights are and how to get care and assistance if you need it right then and there, because there's a lot of pressure on moving the care along and your insurance not covering. So the next slide, please. You want to really make sure that if you have to go to a next level of care, and you have, which is very frequent today, short-term rehab stay, and you'll hear that term. It's important that in today's environment with COVID, that you are able to look up on Nursing Home Compare. You know what the facility's history is with prevention and monitoring of COVID-19. There's been several outbreaks, and most facilities now are not are very much prepared and with the health department. I can honestly say the health department is very much attuned to what the infection rate is and mortality rates. And if you go on New York State Department of Health, you can get that information very easily. Hospital discharge planning, okay. As a caregiver, you're going to be asked, well, what's the plan? What are you doing? And I caution families all the time that there is that push to get them to the subacute level of care, because very honestly, most of the older adults get deconditioned in the hospital. They don't walk them, and it's very, very difficult in a short period of time for them to bounce back at their prior level of functioning. So as you go in to that facility, you really need to know what the time constraints are. And many people, caregivers, they still assume that Medicare covers everything. They will cover for a short-term stay. However, that individual has to be actively participating, and they will only cover first 20 days in full. If you have a managed plan, there are the same type of requirements, but they have to be showing ongoing process, ongoing improvement. And it is important that if they're being told that they no longer need therapy and they've plateaued, everybody has that right to appeal, and most people don't appeal. So it's really important that you're working with an advocate, and we at EverHome work on appeals every day, and most of the time we're successful in winning those appeals. Discharge planning, again, across all of the different facilities in that, there's many different discharge planners, care coordinators. You need to know the role, and you need to know the role of the social worker. And I'm going to ask my colleague Susan to explain the rehab facility process and the types of care and the difference between rehab in a skilled facility versus subacute.
Before you jump in, Susan, I just want to point out that, Nora, you ran discharge planning for the hospital for how many years?
28.
What changes have you seen in discharge planning between when you started and today?
It's a much faster process where people are really being pushed to the brink. Decisions have to be made in light speed. You don't have when I was back started, they used to have ALC units where they could wait until they got that first available bed, but that took months. Now you're down to a process that takes 3 days. Most hospitals stays now are outpatient. It's amazing. So then you have different levels of care, observation versus inpatient. Well, people often say, well, my doctor said that they were admitted. No, observation means they're going to see if you meet the criteria for an acute admission.
And that doesn't trigger your Medicare benefits for rehabilitation. And Susan, your experience prior to going into the care coordination field is in the rehabilitation side at the other major local hospital. Tell us a little bit about that and what you've seen in terms of changes in that rehab admission.
Well, in the rehab admission phase, many times some people would say, I was given a couple choices, and then I had to pick one, and I had to give them an answer in 45 minutes. And it's hard to make those decisions when you have that time limit and you're like, okay, make a decision. Many times people were waiting much longer before coming into the hospital. So once they got to the hospital, their needs were a little bit more than what we had seen. And there were a lot more people with comorbidities or other health issues. And what was happening is that it was taking longer to rehab. And some of the professionals know this, but some of the caregivers may not. There are the two levels of rehab. There's the acute rehab, which is often in a hospital setting, and upstate New York, we're lucky to have two. Downstate, there are more, absolutely, and out west there are additional. And it's very limited. Anticipated stay on acute rehab is a week to 2 weeks. That's it. And then you need to move to your next level. Sometimes people would go home, but sometimes they'd have to go to a rehabilitation or subacute rehabilitation. And Nora, you talked about this a little bit, but in the subacute rehab, they will get a minimum of 1.5 hours of therapy. They can get up to 3 hours, depending if they're able to withstand the therapy and if there is staff availability and ability to do that. And they have about 2 weeks, 3 maybe. And if they haven't met those goals or not making progress at a level that the insurance company expects and has been set, then you have families getting you need to make a decision. You either need to take your loved one home or place them in a nursing home.
And the question of who pays, the last bullet there, is one that we're going to talk a little bit about.
Mm-hmm.
But that factors in, but nobody really talks about it to the patient. And this is where the caregiver gets spun around 3 times and put out the door.
Yep.
They just want to bring their loved one home. That's
Exactly.
where people want to be. And there are special challenges to that now the two of you are focusing your attention on.
Absolutely. Like we said, the adult children aren't around, and we have to help navigate through that, through distance, working with loved ones in other states.
And that's where that assessment process is so vital, because you have to assess not only the patient in the hospital or in rehab, but the home as well, and determine the suitability and the amount of care and level of care that's going to be available. Nora, you and I have talked about this for 20 years. Back when you were at the hospital, we tried to get a clinic started so people could have advanced directives and the right legal documents. How often do you see this as a problem?
It really is a big problem, because what we have a lot of times is some of the older adults will say, "Oh yeah, I executed a healthcare proxy," but they confuse it with their executor of their will. You know, family members sometimes don't know that they were assigned healthcare proxy. And what is really important for caregivers to understand is that, you know, they're like viewed as the quarterback, and they have to pull all these pieces together. And what's important is you can't plan for care unless you have the legal side and the entitlement and the important documents in place. And
For that,
critical
we're going to
piece.
turn it over to my partner, Peter Strauss, who is one of the founders, literally, of Elder Law. And we could talk about Peter's curriculum vitae all day, but suffice it to say that he has been a leader in the elder law profession for how long, Peter? Do you want to say?
Well, I was admitted to practice in New York in 1963, and I got involved in elder law at the beginning in the mid 70s. So yes, I've seen these problems, and the major lesson I learned is what Nora just said: is if you don't have the tools in the caregiver's hands to deal with these problems from the financial point of view and the healthcare decision-making point of view, we have bigger problems. So what this slide's telling us is we've got to do that advanced planning. And it's both the finances and the healthcare decision-making. And the 3 essential documents that lawyers deal with are, first, the power of attorney. Power of attorney is simply a document where the maker appoints someone or more than one. It can be co-agents, it can be 2 or 3, which leads to the question of how they will decide, by majority vote or individually or, you know, unanimity. The power of attorney appoints people to make financial decisions. The choice of the agent, which is the same issue with the healthcare proxy, which I'm going to turn to in a moment, is most critical. With the power of attorney, you're dealing with finances. Who's the appropriate person? Is it the child who's closest? Is it the spouse who may also be having healthcare issues? You need to know that there is a serious problem of financial abuse that we have to deal with. And we pick up those alerts, and we're going to talk about solutions to that later. But in choosing your healthcare agent, consider how trustworthy they are. And I'm not going to put down children, but 75% approximately of all financial abuse is performed by family members, and you need to keep that in mind. So the power of attorney is important. Turning to the healthcare decision-making, we call these advanced directives. You need a healthcare proxy and a living will. What's the proxy? The proxy is the document where you appoint a person to make healthcare decisions for you when you can no longer do it for yourself, when you lack the ability to give informed consent. And the authority of the healthcare agent is triggered by my, okay, my screen went black for a minute. You lose that ability, and your physician needs to certify it. So that's important. Your authority doesn't come to life until a physician certifies that your principal person, your patient, can't make decisions. Now, how does the healthcare agent know what the patient wants? This is really critical. Of course, you should be having these conversations. The joke is, well, we should do it at Thanksgiving, but that doesn't happen. So you need to have conversations with your healthcare agent, and you need a written document which, at least in general terms, expresses your wishes as to what kind of care or treatment you want, or what kind of care and treatment you wish to forgo, particularly at the end of life, where we get into much more complicated, sophisticated, and moral and equitable issues about what the patient's wishes are. Do we respect the old self or the new self? And that's the whole program for another time. But the living will, which we prefer to call a healthcare declaration, guides the agent's decision-making. But here's the problem. Frequently, medical providers don't honor and respect the wishes as expressed by the healthcare agent. The healthcare agent doesn't decide, but the healthcare agent is responsible, at least in the initial phase, to express the patient's spoken choices as expressed in the advanced directives. Now, I want to tell you that in our documents, we have devised some language that we think will go a long way for having healthcare providers honor the wishes of the patient as advocated by the healthcare agent. Now, if you don't have those documents, one thing you can fall back on is a statute in New York. It's about 12 years old now, called the Family Healthcare Decisions Act. So if you don't have a healthcare proxy and or living will or a MOLS document, which is normally signed in the hospital with consultation with the physician, this statute allows family members in order of priority to make healthcare decisions, including end-of-life decisions under limited circumstances. But keep in mind that don't rely on this, because it's only good in a hospital and nursing home setting. It doesn't work, all right? Now, the final point I want to make in developing these tools so the caregiver can work is, if you are faced with a patient who has dementia, more typically of the Alzheimer's type, the caregiver is going to say to me as the attorney, is it too late? Mom didn't sign those documents. Is it too late? And I must tell you, my answer is no. Capacity to sign legal documents is not an on-off switch. It's task specific. The capacity to sign a healthcare proxy may be lower than the capacity to sign a living will, which involves a set of more sophisticated concepts that people need to deal with. So I've written an article which is going to be posted on our website very shortly where I go into this in greater detail, but don't assume that because you've been told mom has moderate or advanced Alzheimer's disease, that it's too late. Have the discussion with your doctor, have the discussion with your lawyer, and maybe we can do that. Now, if we don't have these advanced directives, if we don't have property management tools or healthcare tools, we may be stuck with a guardianship. You don't want that. It's time consuming. And by the way, during the pandemic, the courts were closed. There were no hearings. They weren't taking filings of petitions. What did we do then? It was really tough. So 7 minutes to cover stuff that I could talk for a day, but I'm going to turn it back.
I know you could. I've heard you. But I just want to point out also that Peter runs the guardianship program at New York Law School, and he has for many years, and he's a professor at New York Law School teaching all of this to those law students. And I run into people all the time that have had Peter as their professor, and I think he does a great job teaching because they all glow about
right. And one of the things I think our caregivers need to know is that the decisions that you're making really has to be thought through as a balancing of an individual's autonomy when they're older and ill, and independence and autonomy and paternalism. And it's a struggle. So we try in the law office to develop systems for people that balance those two conflicting interests.
Caregiver challenges are many. Navigating this highly complex system, many people, as I did, turned to my mother's physician and got nowhere. They're very happy to help about her treatment and care in the medical context, but the financial implications and even the home care implications were something that were not part of their world. It's not something that the primary physician is doing. The team that we have put together through Pierro, Connor, and Strauss in our New York City office, Larice Phillips is the bottom left photo, and Peter, and then our Albany team, caregivers, family friend agency, healthcare practitioners, and then the elder law attorney and the care manager. And our staff of paralegals and attorneys works very closely hand in hand with Susan and Nora for our clients to advocate throughout the system. So I think Peter has covered this pretty well. So I'm going to move on to Medicaid and just touch very briefly on what are very far-reaching changes to the Medicaid home care program. We're going to list for you some resources. We've done already several videos, webinars on the Medicaid home care changes, and we're going to give you the citation where you can find those on our website in just a moment. But Medicaid, due to the budget crisis, has brought in, and there's a link right there, you'll see HTTPS, the pierrolaw.com online learning video library. But Medicaid, because of the budget crunch, has put in a look back period. Used to be you could transfer assets, qualify for Medicaid. Now it's going to be 30 months. These are the programs. You have to know the nuances of these programs, which having care management and the elder law attorney together really gives you insight into what Medicaid program is going to be right for that individual. We have clients paying $250,000 a year for 24/7 home care. They can afford it. We have other clients who have no money who are relying on Medicaid, which is now a closing window to eligibility and also to the amount of care being offered through the Medicaid program. So as I mentioned, the new rules will have a 30-month look back and a penalty, a waiting period to get Medicaid in-home help. So if anyone is looking at protecting assets, transferring assets, there is a cutoff date of October 1st. If you do it before October 1st, you will be grandfathered under the old rules. If you make transfers after October 1st, you will be penalized under the new rules. And remember, for chronic care Medicaid, nursing home Medicaid, it's a 5-year look back period with penalties being applied. We've been very fortunate in New York. I speak, as Peter does, across the country. There was no other state even close to what New York had in its home care program. But times are changing. Budget cuts are causing that home care program to be whittled away. and now you have the 2.5-year look back. But even more substantial than that, there are other changes in the evaluation and the standards by which you can access Medicaid. 3 out of 6 ADLs instead of 2 out of 6. Your own physician can no longer provide the assessment. It has to be a state-approved independent physician. They're changing the assessment to an independent assessor. They're creating a uniform assessment tool. Many, many changes that are going to roll out. Again, we cover those in the other Medicaid-specific webinars. But as you can see here, $895 a month of income, $15,750 in total assets. How do you live at home on those figures? So it takes some planning. It takes some coordination. And one of the primary tools, Peter, that we utilize is a Medicaid Asset Protection Trust for our clients, where they can safeguard assets yet still maintain significant control over the situation.
I just want to jump in because we're getting close to the end, but there are other resources that clients should be evaluating if they're caregivers. Do their parents have a home without a mortgage? They may have paid it off. They might be able to get a reverse mortgage. They may be able to sell or borrow against or draw down the lifetime death, the death benefit of a life insurance policy. Check to see whether there's long-term care insurance, and particularly the new hybrid policy. So there may be other resources if Medicaid isn't appropriate, particularly if the family doesn't have other generations they want to leave money to, that they could really draw down that equity to pay for the long-term care or fix the roof or whatever. So reverse mortgages, while expensive, there are options that we always discuss with our clients.
So our firm does free consultations. So if you have people, if you're advising people and you want to get an analysis of their particular situation, we're happy to do that. We have a marketing department that will set up a consultation and get them information. We have guides also on our website, but we'll send them out to the client. And we have a very thorough fact finder geared specifically for long-term care that we recommend you use and we use with our clients, that gets us the information that we need to do that thorough assessment and to guide them. This is a very nuanced area, very technical. You don't want to make a misstep. So gathering up all of that necessary information is absolutely key. And the long-term care questionnaire, again, we'll make it available. It is on our website as well. The Medicaid Asset Protection Trust, we have a full webinar on that, but it is a trust where assets can be safeguarded. The client can keep the income, the right to live in their home. They maintain very favorable tax treatment, and that trust is still around. And if you get the assets in before October 1st, then you beat the deadline. And if you need home care, you're not subject to that 30-month look back. It also, again, starts the clock, 5-year clock for nursing home Medicaid. So with that, we're going to run about 5 minutes long. I just want to give you a heads up. Due to the storm, we've had some technical difficulties and difficulties with our system, but we're now going to look at a topic that I think is really exciting. And it's something that is technology driven, and technology, if you are a stock investor, all of the stocks that are hitting the roof are technology stocks. It's also permeating the home healthcare system. And for that, I'm going to reintroduce Susan Vail.
Thank you, Lou. We have a lot of different technologies that we look at. There's not one solution that meets all the needs. And I love your comment on the slide, Lou. You always say that. One of our solutions that we utilize with our clients is e-caring. Often when I go into a home, they will have a pile of papers, pretty much like this. And maybe there's a note somewhere written on there, and on there may be something important that I was supposed to see or the family members are supposed to see. What e-caring does is it takes all the information, the care, the mood, vital signs, and allows a caregiver to put it, or a provider, and put it right into a tablet. It's icon based, and I know it's hard to see. You can see it on there. And as a care manager, I get real-time alerts, the family gets real-time alerts, and we know exactly what's going on and can prevent look at preventing an issue if we start seeing a change in behavior, a change in cognition, a trend of not taking medications. It connects the caregivers to the family, and we have that ongoing monitoring. In our next slide, you'll see that it's proven to have improved communication and collaboration. It has definitely decreased hospital admissions. One of the clients we work with, I got a call from the doctor. We were having blood pressure issues. I was able to send the records over, and we prevented having her have to go to the doctor or the hospital because we were able to just send that and a medication adjustment could be made. And then it allows us to better monitor and coordinate the care. We're not taking place of the doctors. Often we try to engage the doctors in the process, and doctors can actually be part of the e-caring alert team so that they can get those alerts. But that's only one part of the solution base. Some of the other technologies we look at are camera and sensor. When you think of a bed alarm, you think of the hospital one that beeps and is really annoying when you roll over. Technology has changed. There are bed sensors that we can put in the community that will sense if your loved one has not gotten out of bed or has gotten out of bed and has not come back. And we look and figure out what sensor or technology is going to work best. There are voice activated lights so that you can say light on if it's a fall risk in the middle of the night. And we look at what's the best solution set for your loved one or for yourself. It involves PERS or Lifeline, and the intercom. Many people use Facebook or FaceTime, but this allows you to talk with your loved one. It helps with dementia. They may not recognize your name, but they may recognize your face, and that brings them peace. But we utilize alarm.com. They have a wellness division that we work with to help better our clients' lives.
Susan, I just want to jump in. When my mom had
please go ahead.
and she lived an hour away, none of these technologies existed. There was a notebook on the refrigerator. Who were these women coming into my mother's house and spending 8 hours a day with her? I didn't know them personally. I had interviewed them and we hired them. But what were they doing every day? What was the activity, and what was my mother's condition? How was she feeling? How was she being treated? What was her blood pressure, her diabetic glucose levels? All of those things get measured, monitored, and inputted into the system, and it becomes a cloud-based record, and your care coordinator monitors that. And if it's outside of the care plan, the readings come back, blood pressure's high, it's going to trip an alarm. You get that alarm on your cell phone. The care manager gets that alarm on their screen. And now you've got an ability to triage situations without having to drive that hour and get the care and get the intervention that you need. So alarm.com, e-caring, there are other technologies that are on the market that are being integrated that we're bringing into the care. And if I had those for my mom, it would have been a heck of a lot easier. We are now fitting up my aunt for all of these technologies in her home. She turns at 98 next week. And she's getting the sensors and the care management software, the e-caring software. So it's something that now we have an ability to bring solutions in, and it's a lot less expensive than 24-hour-a-day hands-on care. But again, it doesn't replace the caregiver. It just aids what they do and helps the family communicate. And this is kind of one of the exciting features that COVID-19 has accelerated: telemedicine.
Yes. And we've partnered with United Concierge Medicine to provide that. Now up in upstate New York, locally, two of the healthcare plans have already partnered with United Concierge Medicine, CDPHP and MVP, but it gives you a virtual ER in your home. These are ER physicians who will triage. You don't have to be lying on a gurney or a bed for 3 hours hoping you'll see an intern or maybe a medical student. You connect via your phone or your tablet. They did a pilot project with Rensselaer County, and they have proven to, as it says, to reduce the ER trips by 97%.
And as a result of COVID-19, two of our major local health insurers, MVP and CDPHP, picked it up and made it available to all of their insureds. So telemedicine, the president has talked about it, CMS has talked about it. Telemedicine is going to be part of our future. We think these other home care technologies integrating with that telemedicine provides a very, very powerful solution. And if we had that 20 years ago, my job as a caregiver would have been infinitely easier, and I could have done it with the comfort of my cell phone, you know, managing the care in a way that was efficient, cost-effective, and better, improving the quality of care while resolving those caregiver issues that we had. And that's what's available today, telemedicine being the capstone of that. I mentioned earlier that we have resources available, our video library. We have videos and webinars that we've done in the past that are broadcast on our website free of charge on estate planning, long-term care planning, Medicaid, the Medicaid Changes, Medicaid trusts, special needs planning. We have a webinar coming up on the 19th. If you're interested in special needs planning, we have a special webinar with Peter Strauss, Larice Phillips, myself, talking about SNTs and special needs. And always visit our website for upcoming programming. Very happy that you could join us today. We hope today's information was helpful. Thank you, Peter, for taking your time, and Susan and Nora to be with us today as well. Have a great day all. Stay safe.